We're jumping into something that honestly sounds a bit like science fiction, but it's very real. A procedure performed before a baby is even born. We're focusing on Vein of Galen malformation, VOGM for short. It's rare, yeah, but it's an incredibly serious issue where blood vessels in a developing baby's brain don't form right. This can lead to, well, devastating problems right after birth. The outcomes historically, they've been really tough. So our mission today is to unpack this groundbreaking approach in utero embolization for VOGM. It's truly a new frontier in fetal medicine, offering real hope. And guiding us, we're leaning on the expertise of absolute leaders.
Right. Hey there. Want to share your thoughts on this?
Hey, how are you? I'm Dr. Reza Lankrani is speaking. First of all,
Oh, absolutely. We love when you join in. It makes this so much more interactive.
Yeah, please feel free to jump in with any.
Oh, go for it.
wanted to mention that this review of mine is based on recent article of Professor Alireza Shamshirsaz. He's professor of obstetrics and gynecology at Harvard Medical School, and he's chief of division of maternal fetal medicine and surgery, and also director of fetal care and perinatal surgery fellowships. So I deeply appreciate.
Thank you for highlighting that. It's actually a wonderful point to bring up.
Yeah, you've really honed in on a key detail there about Professor Shamshirsaz's background.
His extensive expertise as a professor at Harvard Medical School and chief of fetal medicine and surgery.
And director of surgery, as you said.
All of that underscores the rigorous foundation for this groundbreaking work.
It's not just a procedure, it's backed by incredible academic and surgical leadership.
Your observation.
Hey, yeah, what's up?
And at last, I wanted to sincerely thank you for your wonderful program, podcast, and I just wanted to say how much I appreciate your work and hope to.
Wow, thank you.
That's incredibly kind of you to say.
Seriously, that means the world to us.
Hearing that you appreciate the program truly makes our day.
We put a lot of effort into making these podcasts, so that feedback is just gold.
It really encourages us to keep diving deep into these complex and fascinating topics.
You know, your appreciation also perfectly illustrates the multidisciplinary effort required for this kind of advanced fetal intervention.
Absolutely. The communication we foster here is part of that.
It really emphasizes the caliber of the team involved, which we touched on earlier, and the importance of sharing that knowledge.
It connects to that importance of clear communication we were just discussing.
Sharing the credentials and the roles, like you just did earlier, helps everyone understand the context.
So thank you again for that valuable insight and for being such an engaged listener.
Seriously, your appreciation means a lot to us.
Precisely. It's about translating that cutting-edge research into accessible, even actionable information.
Whether it's for clinicians in training or for families facing this diagnosis, clear communication is vital.
We aim to make these complex topics as clear and engaging as possible, just like you appreciate.
So thank you for being a part of that. We really do love your interjection. And guiding us, we're leaning on the expertise of absolute leaders. Tremendous respect to Professor Alireza Shamshirsaz, a fetal surgeon, dual board certified, and director at Boston Children's Fetal Care and Surgery Center. And our conversation is also deeply informed by a review from Dr. Reza Lankarani, a general surgeon, founder of the Surgical Pioneering newsletter and podcast series, and on the editorial board at Genesis Journal of Surgery and Medicine. Okay, so let's dig into VOGM a bit more. You said it's the most common congenital cerebrovascular anomaly. What exactly is going wrong inside the brain there?
Right. So, VOGM isn't just like a blockage. It's a fundamental hiccup in how the brain's veins develop very early on.
Yeah.
There's this specific vein, the median prosencephalic vein, that's supposed to basically disappear. But in VOGM, it doesn't. It sticks around and swells up into this big abnormal pouch called a varix.
Varix, okay.
And this varix, it acts like a massive short circuit. It starts getting blood pumped directly into it from arteries at really high pressure. So blood flow gets totally rerouted in the fetal brain, bypassing the normal pathways.
Wow. And that rerouting causes the problems.
Exactly. The consequences are huge. We see severe issues for the baby right at birth, really high mortality rates, unfortunately, significant risk of brain injury, and major developmental delays down the line. There was a key JAMA study that put numbers on it. If the main draining channel, the falcine sinus, gets to about 10.3 millimeters wide, well, the outlook was grim, like 90% expected mortality.
90.
Yeah. And only maybe a 9% chance of hitting normal 6-month developmental milestones with the standard care available after birth. It really paints a picture of why intervening earlier becomes such a critical goal.
That statistic is just staggering. It makes it so clear why this new procedure is potentially revolutionary. So this is where it gets incredibly fascinating, the embolization. How does that even work? Performing brain surgery on a fetus inside the womb.
It is pretty amazing. And the early results, again, from that JAMUS study are really encouraging. They enrolled 7 patients, and 5 actually underwent the embolization successfully.
Okay, 5 successful procedures.
And get this, out of those 5, 3 babies survived the critical newborn period. And all 3 of those survivors showed no neurodevelopmental delay later on. Plus, scans after the procedure didn't show significant new brain injury, which is obviously key.
That is a world of difference, going from that historical 9% chance of hitting milestones to what did the study find post-embolization?
It was 43% meeting milestones at 6 months. Still early data, of course, but a huge jump. And it wasn't just about survival or development. They measured the load on the baby's heart. It put immense strain on the fetal heart. After the embolization, they saw, on average, a 33.4% reduction in that cardiac output. That tells you the procedure is actually tackling the core problem, easing that strain.
Okay, so the results are promising, but the procedure itself, drawing on Dr. Lankarani's review, how do they technically achieve this? It sounds incredibly complex.
Oh, it absolutely is. Meticulous doesn't even begin to cover it. It starts way before, with imaging. Really high-resolution ultrasound in the 3rd trimester usually picks it up. First, you see this sort of mass in the middle of the brain with chaotic blood flow.
Okay.
Then fetal MRI comes in. That gives much more detailed anatomical information, different planes, and crucially, it lets them measure that falcine sinus. If it's 7 millimeters or wider, that's a key factor for eligibility.
So the MRI confirms and measures.
Exactly. And they even use things like MRA and MRV, specialized MRI for blood vessels, plus 3D fetal brain maps. They can even overlay the ultrasound and MRI data. It's like having this incredibly detailed, multi-layered GPS map before they start.
An internal GPS. Wow. Then comes the really tricky part, I imagine, getting into the brain.
That's the transuterine transcranial needle access. Yet technically very demanding. The mother gets spinal anesthesia, keeps her comfortable, relaxes the uterus. Then the fetal surgeon actually gently manipulates the fetus from the outside to get the head positioned just right.
Okay, real-time adjustments.
All under constant ultrasound guidance. Then they guide a special needle. It's an 18-gauge Chiba needle, long and designed to be seen well on ultrasound, through the mother's abdomen, uterine wall, and then carefully through the fetal skull.
Through the skull? How does that work?
It's still developing. The calvarium isn't fully hardened bone yet. Sometimes they use a very specific, gentle rotational movement with a needle tip to kind of ease it through that developing bone layer.
Incredible. And once they're through the skull?
Then comes the micronavigation. They use incredibly fine, flexible tools. A microcatheter, think a tiny tube, like less than 0.5 millimeter wide inside, and a microwire, even thinner, super soft tip.
Wow.
These are threaded through that first needle coaxially. And they use these to navigate very carefully through the fetus's delicate brain vessels to reach that target varix.
So they've navigated the internal GPS, placed the needle, and threaded these micro tools right to the spot. Then what? How do they fix the malformation?
That's the embolization itself. They deploy tiny detachable platinum coils. These things are incredibly soft and designed to pack into spaces.
Coils, like little springs.
Sort of, yeah. But the goal isn't to completely block off the varix. That could be dangerous, cause a backup, maybe venous infarction. Instead, it's strategic. They aim for about a 20% packing density.
20%? Why that specific amount?
It seems to be the sweet spot. Enough coils to significantly slow down that high-pressure arterial inflow, reducing the shunt, but not enough to completely stop the venous outflow. It attenuates the flow, dampens it. They release these coils very precisely using a special detachment system.
A controlled reduction, not a total stop.
Yeah.
Got it. And all this time, what about the baby? They need to be perfectly still, right? And comfortable.
Absolutely critical. Fetal anesthesia is key. The mom's spinal helps, but it's not enough for the baby during such a stimulating procedure. So the fetus gets its own medication directly injected into a muscle, again guided by ultrasound.
What kind of medication?
It's usually a combination. Something for pain, like fentanyl, something to ensure complete stillness, a muscle relaxant like vecuronium, absolutely vital when you're working near critical brain structures, and something like atropine to keep the heart rate stable, prevent it from dropping too low.
Direct injection for the fetus. It really highlights how every single detail has to be managed.
It really does. And stepping back, we have to talk about the risks too. It's groundbreaking, but it's not without potential downsides.
Right. What are the main concerns?
For the mother, there are risks like the water breaking early, preterm labor, or bleeding. For the fetus, the concerns are things like bleeding inside the brain, potentially causing new or worsening brain injury, infection, the procedure maybe not working, or even, in the worst case, fetal demise. These are serious potential complications.
And that trade-off you mentioned earlier from the JAMA study,
Yeah,
the reduced mortality risk versus preterm birth.
exactly. That's a really important point from the study. While the procedure offers this incredible potential benefit for survival and brain health, it did increase the chance of an unscheduled, often preterm delivery.
Yeah, you said 71% had unscheduled deliveries, and many were preterm, often just days after the procedure.
Correct. So it's like a complex calculation of risks and benefits that the team and the family have to weigh very carefully. It underscores the high-stakes nature of this intervention.
So how do they manage all this complexity and risk? You can't just have one person doing this.
No way. This absolutely requires a massive, multidisciplinary team effort. It's like a surgical orchestra. You have the maternal fetal medicine specialists, often working with neurointerventionalists who are experts in vessel procedures.
Okay.
Then pediatric neurosurgeons are involved, fetal cardiologists monitoring the heart, obstetric and fetal anesthesiologists managing both mom and baby sedation and comfort, expert sonographers providing that real-time imaging guidance.
The list goes on.
It does. Neonatologists ready for the baby after birth, specialized nursing staff, research coordinators managing data. It's a huge collaboration. And they often do extensive pre-procedure simulations, mapping out everyone's roles, planning for contingencies. That teamwork is paramount for safety.
And monitoring must be constant before, during, after.
Continuous. Fetal heart rate monitoring throughout, detailed fetal echocardiograms to check the heart function, fetal MRIs before and after, and then, crucially, long-term follow-up is built in. Neonatal brain MRIs after birth, regular neurodevelopmental testing as the child grows. You need to track the outcomes over years.
It's just an incredible undertaking. So bringing it all together, for families who receive this VOGM diagnosis, what's the core message here? What does this breakthrough really mean?
I think the core message is one of significantly increased hope. While it's still early days, this data suggests a real possibility of not just survival, but survival with normal neurodevelopment. For babies with high-risk VOGM, that's a profound shift from the historical outlook. It offers a tangible pathway forward where options were previously so limited.
And it's not just doing the procedure, but sharing the knowledge, right? You mentioned Dr. Lankarani's review highlighting the educational tools.
Yes, that's so important. Things like detailed diagrams showing the anatomy from different angles using 3D models. These aren't just academic exercises. They are vital for teaching other teams around the world how to even approach something this complex. Disseminating this knowledge safely and effectively is key to making this kind of advance accessible.
It really feels like a major leap. It gives hope for these specific families, yes, but it also feels like it pushes the boundary of what's possible in fetal medicine overall.
I agree. It sets a precedent. It shows that with the right imaging, the right tools, the right team, and meticulous planning, we could potentially intervene effectively for complex problems even before birth, potentially mitigating long-term disability.
So that wraps up our deep dive today into this truly remarkable procedure in utero embolization for vein of Galen malformation. An incredible blend of innovation, precision, and teamwork. And just think for a moment, imagine the ripple effect, the profound difference early intervention like this could make in a child's entire life trajectory. What other fetal conditions might become treatable in the future thanks to pioneers paving this path? It really does open up a whole new realm of possibility. Once again, our deepest respect and acknowledgement to Professor Alariza Shamshirsaz, fetal surgeon and director of the Boston Children's Fetal Care and Surgery Center. And this deep dive drew heavily from the profound review by Dr. Reza Lankarani, general surgeon, founder of the Surgical Pioneering newsletter and podcast series, and editorial board member of Genesis Journal of Surgery and Medicine. If you want to explore the source material further, you can find the JAMA article abstract and Dr. Lankarani's review at the links provided in our show notes. They are https://jamanetwork.com/journals JAMA article abstract 2837548 and https://surgicalpioneer.code.dx.